has been observed that there is an increase in pre-hypertension cases. So cases that are lingering on the side of hypertension, but not quite there. So we have about 46.5 or 3 million among males and females. Females are a little bit less. That's based on the Ministry of Health 2017 consensus report. So it's still a big problem, still significant, but why is it significant? What's the big deal about hypertension? I mean, it's just high blood pressure. Why don't we just leave it there? It actually has more to do with cardiovascular risk and end organ damage. So if you leave blood pressure high for a long time, it has some correlation with cardiovascular morbidity and mortality. Has risk of stroke, increased risk of MI, kidney disease, early death, you name it. Okay, so that's as you think about these chronic disease states, always think about the end result. Don't think about the disease itself. For blood pressure, we have systolic and diastolic, right? So when you report the blood pressure, you report it like 140/90. So systolic blood pressure is a strong predictor of cardiovascular disease, unfortunately, in adults. End organ damage, it accelerates atherosclerosis, stimulates left ventricular dysfunction, as we see with heart failure also. It also promotes vascular dysfunction as well. So the longer you wait, the more significant damage happens, okay? And that include also retinopathy, strokes, TIAs, MIs, peripheral artery disease, PAD, and vascular dementia. So it can cause a plethora of things if you think about it. One of the things that we're trying to advocate for early detection and treatment, right? So look at this data here. So this is a data from 300,000 patients, okay? This is from about 74, 75 trials combined together to try to advocate or show the effect of treatment. So this is the effect of treatment to lower the blood pressure at different blood pressure levels in primary prevention, okay? We'll talk about what primary prevention is, but look here. So if you look at the relative risk, so anything that crosses 1 has almost no benefit, but look at on the left side. A lot of these dots actually do not cross 1, do not cross this middle line, and that favors treatment. So if you look here, heart failure, end-stage renal disease, maybe a little bit, stroke favors treatment. You lower the risk of stroke or relative risk of stroke, especially as the blood pressure, the systolic blood pressure goes high. So look here, so treatment is more effective at higher blood pressures. Okay, and you see it apparent here and you see it apparent here. So that tells you collectively, if you look at the majority of the population, you actually are more prone to, or you want to treat blood pressure, higher blood pressure, instead of just leaving it alone. Okay, so my question to you now here, what is primary prevention means? What does it mean? We say primary prevention. What does that even entail? The word primary, what does it say?
High blood pressure caused by non-secondary diseases, like it's normal or genetic, could be familiar.
Exactly. Very, very, very good. So primary means it's nothing else caused it. We don't know the cause for it. And so it's the first layer of issues that the patient has. Okay. So it just came along as an issue by itself, isolated. Okay. That's primary prevention. So as we talk about secondary prevention, that's a different story because you have an underlying issue you have to take care of before you actually fix the blood pressure, right? So if you think about blood pressure, high blood pressure as a problem occurring after a stroke, for example, if the patient strokes out, the blood pressure will go up. Now we can't treat it this way. We can't go with ACE inhibitors and ARBs and things like that. We have to take care of the underlying issue first, which is the stroke. So primary prevention is a term you will see coming up and up again as we talk about different disease states, especially in chronic management of disease states. Okay, so let's shed some highlight on hypertension during pregnancy because it's called different names, right? So you have gestational hypertension, preeclampsia with severe features, and then we have something called eclampsia, right? So we're not going to go through it. Just remember that in hypertension, in pregnancy, things tend to be called differently and managed differently, as well as the complications will be different, because the hemodynamics in pregnant females is so much different than just a normal female, right? We all know that. So just look at this slide as you go. I just wanted to include it here, so just to shed some light on what happens during pregnancy, okay? As well as other forms of hypertension, if you think about what happens if somebody comes to the ER with a very, very high blood pressure. We don't really call it hypertension, we call it hypertensive crisis, right? You have urgency and you have emergency, depending on what's actually happening. But also look at these and look at the criteria. So it has to be very, very high blood pressure, usually above 180 over 120. Okay, we manage those differently. They don't fit in the picture that they don't fit the theme of this lecture. Okay, this lecture is primarily talking about primary prevention and treatment of just chronic hypertension, so essential hypertension. Okay. Okay. So non-pharmacological therapy for hypertension, because if you don't have to give drugs, that would be a good thing, right? We're trying to minimize unnecessary interventions with these patients. So the DASH diet, anybody know what the DASH diet is?
Yes. Yeah.
I mean, it's written here, but have you heard about it before?
Not before I studied the case.
Okay. So it's something out there. There's a lot of literature on DASH diet. You can read about it. There's a lot of pamphlets you can give to your patients as well, if you want to manage hypertension, especially in the early stages where you really want to do some change that is non-pharmacologic. You know, you really want to do an intervention on top of the pharmacologic therapy if you choose to do so. Okay, so this is involving just a healthier form of diet with fruits, vegetables, low fat, reduced saturated and total fat. Okay, so the best literature I can find on the DASH diet is that it reduces systolic blood pressure, which is, we said, it's already an indicator or tightly indicated with cardiovascular disease, right? So this is the blood pressure we want to lower, the systolic one. It lowers it by about 11 points. So is that a significant blood pressure reduction? So let's say the patient is at 151, we lower it to 140. Is that a big deal or it's not too much?
Yes, I think so.
Yeah, it is actually a big deal. This is as good as some of the medications we have, right?
Nice.
So the more you lower it, I mean, the effective you lower it and you make it maintainable at a normal blood pressure, especially systolic, the better it is. So 11 is actually very significant. That's about 8, 7, 10%, right, of the total blood pressure for the patient. So that's very good. Salt intake is also recommended to be reduced, 1.5 gram daily intake limit. That will reduce the systolic blood pressure pretty lightly, but something not very significant, but at least it's a low-hanging fruit for the patient to do. Physical activity, 30 minutes a day, most days of the week. When you say most days of the week, it doesn't mean 1 day or 2. It means like 3 and more. Reduction and a little bit higher than salt intake. But all of these things you should inject in the patient's daily routine. These are healthy habits, so they can do that. Okay, now to the pharmacological treatment. This is just to show you what's available out there. This is everything we're going to talk about. As we go, just please make note on important drug classes that we really care about. Some of the drug classes like renin inhibitors, to some degree diuretics, and to some degree some osmotic agents we're going to talk about. These are not very important in blood pressure. They do come apparent in other disease states, but we're going to highlight that as we go. Okay, so who knows ACE and ARBs? Have you guys heard about ACE and ARBs before?
Yeah, we did, actually.
Okay. To what degree? Do you guys want us to go through everything, or do you guys are okay with the mechanism of action and we just go about, because I do have some kind of tips and tricks of how to remember these things.
Well, let's get it.
Yeah, we need to remember.
Sorry?
I mean, yeah, we need to remember it. So we can go through it all. If you
Okay,
want.
okay. So ACE and ARBs, think about them as cousins, right? Or maybe closer than cousins, maybe brothers, okay? So they do actually work about the same way. They do effectively, they do the same thing, but we'll talk about when you're gonna prescribe one over the other, okay? So ACE inhibitors, that's your prils, right? Ramipril, fosinapril, perindopril, lisinopril, enalapril. Do you guys know what's the oldest one of them? From all of these, what's all of the trials are about, like the old trials? If you look back, what's the first one?
Lisinopril, is it?
Actually, Ramipril. Ramipril is the first one that came out, and then all of them came after that. Ramipril, it's not just the oldest by history, but I mean it's the oldest by studying. So most of the trials you're going to find the old ones on Ramipril. Okay. But they all effectively do the same thing. The difference between them is dosing. Some of them are dosed twice a day, some 3 times a day. So the half-life of them are different. The most common ones will be your lisinopril, captopril, perindopril, and probably enalapril. Okay, these are the common ones. You're not going to see fosinapril or moxapril. These are very, very rare that you can find because there's no reason to have them really. Okay, so the most important thing to remember here, that first line treatment for hypertension as well as some other disease states. They are always indicated first line. So they are very important medications to remember. Okay. The way they work is they work on this little enzyme. Okay. So what they do effectively is, so let's try to draw a kidney. Supposedly this is a kidney, okay? So effectively, once you inhibit the enzyme, okay, what happens really in the physiologically, what happens? You guys know?
You mean the function of the angiotensin II or
Like
what?
what happens? Why the blood pressure goes down? What really happens? Okay, so you inhibit this enzyme. So what effectively happens?
The vasodilation of the vessels and
Not any vessel, right? Specific vessels.
Efferent?
Yes, with an A or with an E?
Efferent construction with E.
With an E, exactly. So right here, right? So you will have dilation actually here in the efferent, right? This is the afferent arteriole that coming to the kidneys. This is the efferent arteriole that going out of the kidney, not the kidney, but the glomerulus, right? We're just talking about the kidney in general because effectively this is what's going to happen when you have these million nephrons, right? So what happens is that you dilate the efferent, right? What's coming out. So what happens to the blood pressure inside here? It goes down, right? So you decrease the blood pressure.
Yes.
Okay. That's good. So what's the percentage of blood that goes to your kidneys if you have 2 healthy kidneys?
20%.
Yeah, about 20 to 25%, right? So about quarter of your blood supply goes to your kidneys. So if you dilate or if you try and effectively to reduce the blood pressure within the kidneys, that's a significant impact on the whole circulation, right? Because you're impacting about 25% of the blood supply. The problem that comes with that is how do filtration happens? It happens by pressure, right? You need pressure to actually filtrate things. That's how the kidneys work, right? So you need effective blood pressure to actually filtrate. So let's say that blood pressure got cut off by mistake. Maybe we have an MI, maybe we have asystole for a few minutes. The first thing they're going to take a hit is the brain, then the kidney, the liver, all of these vital organs, right? That's why when we are reducing the blood pressure within the kidney, we have to be mindful of a few things. One, if the patient has some sort of a medication that constricts the efferent arteriole, and then we come along and we dilate the efferent arteriole, what's going to happen to the blood pressure here? It's going to even drop even lower, right? Because you're closing the entry and you're opening up the exit, right? Can you think of a blood pressure of a, sorry, not blood pressure. Can you think of a medication that does that here?
I think ACE inhibitor.
We already said ACE inhibitors work here.
Yeah.
What works here? Very
Oh,
common
sorry.
medication.
Six.
Say that again.
Non-steroidal anti-inflammatory drugs.
Exactly, NSAIDs, right? So non-steroidals, your ibuprofen, your ketoprofen, your diclofenac, your Cilindac, all of these medications actually vasorestrict the afferent arteriole. So let's say somebody, you gave him ACE inhibitor and they're on ibuprofen daily 600 milligrams. This is a very risky recipe for acute kidney injury, right? So you're going to give them AKI without knowing, because you did not ask about, sorry, I can't see my pointer here. So AKI, this is a K, sorry. So you're going to give them an AKI without you knowing that you could actually precipitate AKI. The reason is you kind of give the kidneys a double hit in this way, because you vasoconstricted what's coming and you dilated what's going. And in this way, you can give the patient AKI. So that's why the risk comes in. So you have to be very mindful of who you give this medication to. Ask the right questions, okay? And if the patient needs maybe 1 dose of ibuprofen, that's totally fine. But ibuprofen and all of these NSAIDs, they dilate, they vasoconstrict the afferent arteriole in a dose-dependent manner. So if the patient suddenly takes 600, 800 milligrams of ibuprofen, for example, they could actually get an AKI, okay? So just be mindful of that. Another thing to think about is they actually cause dry cough. And the reason they cause dry cough, anybody knows why this dry cough happens with specific medications?
An increase with the bradykinin.
Exactly, because once you stop this from going further, once you stop this reaction from going further, a buildup here will be bradykinins, and the bradykinins exist in so many tissues, including the lungs, and so you get this buildup of bradykinin that will give you dry, constant cough. This is a classical symptom. This cough is nothing like any cough else. It's a very distinctive cough. You can really guess that this patient is he has a new ACE inhibitor prescription, okay? So the risk is different. So 5 to 10 to 20% in some studies. That's not the same case with ARBs, because ARBs, what do they work? Down here, right? So if you block the enzyme only, you're gonna effectively block the whole mechanism. You're gonna halt the whole mechanism. So the bradykinin buildup with ACE inhibitors is much higher than the buildup with ARBs. Okay, but the percentage here is a little bit less. So it's less than 10%, but who knows? I think some studies will give you 2, 3, 4, up to 5% of risk. So that's my question for you. If I'm diagnosed with hypertension, God forbid, today, and you determine that the first line treatment is ACE or ARB for me, okay? Which one would you give me first? Guidelines recommend the same thing. They're all recommended. They're all okay. They're all safe. They're all available in your pharmacy. But you're writing the prescription and you're trying to decide between these two. Which one would you give me first?
If you have money, I will give you ARBs.
If I have what?
Money.
You know, we all don't have money.
Okay, ACE.
Okay. Now, cost is out of the picture. Let's say it's a free healthcare, like alhamdulillah here in Saudi Arabia, it's free healthcare. You can give anyone.
Doctor, maybe we should consider if
Sorry,
the
go ahead.
patient has asthma or not, so we don't make it more severe.
Think about it more in the logistic side of way. Which one, if you gave first, you have a better chance of treatment?
ACE inhibitor.
Yes.
ACE, of course.
Exactly. Not that because they work better, they all work about the same. So I know this is a receptor blocker and this is an enzyme inhibitor. They all kind of give you the same effect. The question here is, let's say you give somebody an ACE inhibitor An ARB, sorry. You started with an ARB, okay? They're new, they are ACE or ARB naive, they have never received this treatment, you give them an ARB, okay? And they do develop dry cough. They do develop this dry cough, okay? Can you give them an ACE now? Can you switch them to an ACE? No, you can't, because the
No.
risk is higher with ACE inhibitors. So if they get cough with an ARB, they will sure get the cough with ACE inhibitor, okay? But if you start with an ACE inhibitor and they get a cough, next time they come to your clinic, you can switch them to an ARB, and most likely they will have some chance of success with this treatment, and the cough may goes away, it may go away. So always start with a higher risk and then go to the lowest risk. Because if you start here, you already eliminated this option. If you start here, you keep this option open. Okay, that's a very key treatment. I don't know what we call it. It's a clinical pearl. It's very important to know, because physicians usually think they're the same. They are effectively the same, but think about this patient. So you really don't want the patient to miss taking an ACE or an ARB, because they have a long-term beneficial effect, cardiovascular protection. They have renal protection effect. They have so many things for diabetics, for heart failure. They're very useful, but try to minimize the risk of making them useless. So try with an ACE first, then go to an ARB. Okay. So if I ask you in the exam, or you see it on the on the board exam or anything, and both drugs are indicated, I mean, if they're all indicated, they're going to be always indicated together. If they are contraindicated, you can't use any of them. So whenever they're indicated, they're going to be indicated. You will have two options together. But the problem is with the cough and the angioedema. So once you give one, you can't give the other if you start with an ARB. So always start with an ACE so you can go to an ARB. Okay. Always remember, contraindicated in pregnancy, renal artery stenosis. Why is that a big issue? Renal artery stenosis. Why are they contraindicated in that?
The flow already declined.
Exactly. Same picture with the NSAIDs, right? And then also with impaired renal function. In some studies, you will find, and actually I have seen it in practice, once you start an ACE or an ARB, there is a slight bump in serum creatinine. It goes up, meaning the renal function declines a little bit, but that's just a timely thing. It goes back to normal after a while. So don't freak out once you start an ACE inhibitor and you check the patient serum creatinine after a few days and it's high. It's like it goes from 1 to 1.3. That you're not putting them in a danger. It's okay. Usually there is a slight bump because the hemodynamics of the renal hemodynamics will change, and the body will effectively adjust to it. Okay. Fasinapril is the only one that is eliminated via hepatic and renal routes, so it's a good option for renal patients with renal issues. But effectively, you're not going to be using these agents with renally compromised patients. Okay. Remember, pregnancy. When do patients know they're pregnant? First trimester, second trimester. When do they actually know that they're pregnant? If a pregnancy happens, unplanned.
First trimester.
Second.
What week, actually? Usually what week the patient knows? Not the first week, right? Nobody will know in the first week unless they plan something. They will test because nothing shows up, no changes, no physiological changes. They don't feel anything. Maybe some nausea from the week 3, 4, 5. Typically, patients feel they're pregnant in the 8th week. Okay, so about 1.5, 2 months into the pregnancy. So once they know they're pregnant and they're already on ACE inhibitor ARB, the damage has already been done. Okay, because they do cause a lot of issues for the fetus in the beginning, in the first trimester. So always try to plan things with your patient. If you're putting somebody on an ACE and ARB, make sure that please don't give a 28-year-old female, a child bearing age female, married female, ACE and ARB unless you ask. And especially ask if you're planning to get pregnant, please consult with us before you do so, because we might have to change your medication. Okay, this is very important key point here. Okay, less effective and less used medications is the renin-angiotensin, the renin-angiotensin system, the direct renin inhibitors here. The only one here I know is alicycline. I have never seen it. I don't think it's used It has very unclear therapeutic value in hypertension. One thing to think about is, can you combine ACE or ARBs or director inhibitors together? Can you mix and match together as a concomitant therapy?
No.
What's the problem if you do that? It might be a board exam as well.
I guess you will impair the renal modulation of bodily fluid or infiltration.
Exactly. So more risk, less benefit, right? So you will get all the side effects with no additional benefit. That's basically what's going to happen. Okay. So think about that as you think about medications being used together. This is just a blowed up screen of how things work, just for your own benefit, because I think it's colorful. It's going to help you know where each medication works. So ARBs work here, ACE inhibitors work here, and anticyclin works here. Okay. This is also for your own benefit. Also, what happens with angiotensin 2, because we do effectively block angiotensin 2 with ARBs. So if you're curious about knowing what's happening exactly, once you block this, this is what happens. So you can read it in your own time. ACE inhibitors, I put them all together, or diphtheria, put them all together here. So they're listed here. For all of these drugs, you will see us actually putting the mechanism of action here. You will see what the action happening here, and then the most common adverse effects. You might have to think about with these ACE inhibitors, ARBs, hyperkalemia. If the patient is prone to hyperkalemia to begin with, I mean, you guys know now in social media, people are taking potassium as a supplement. Everybody's rooting for its huge beneficial effects, and TikTok and Snapchat and whatever. So if the patient already taking potassium and you put them on ACE inhibitor, you can cause hyperkalemia. It's a big thing. Why is hyperkalemia a big deal? Why do we care about potassium so much?
Affect the heart function.
Because of the heart function, heart rate.
Exactly. So what happens if somebody is in severe hyperkalemia?
Maybe
Cardiac arrest. Cardiac arrest.
Yep, that's the problem. So they die. Okay. So that's not a good thing to happen. If you're trying to think about it, I think it would be a good idea to get, probably get baseline labs and see where we're at with the potassium. You can't assume that the potassium is normal and then see what happens in a few weeks. It's always a good idea to get these labs beforehand with starting these medications, and then maybe 1 or 1.5 months later, you can check and see if the serum creatinine went back to normal, if the potassium is okay to continue these medications. Okay. Okay. Same thing with the ARBs. Basically, they're brothers. They're almost the same. Think about the names. So the sartans are your ARBs. Probably the most common ones you're going to see is candesartan, irbesartan, losartan, telmisartan, and valsartan. Most of them are actually available in the market. Iprosartan, I have never seen. Honestly, I don't think it's available. I don't think it's approved in Saudi Arabia or the US. Okay. And your renin inhibitor is also available. But again, you're not going to see this probably for a very long time. Okay, let's jump to diuretics now. You guys are familiar with diuretics, I'm pretty sure, because it comes in so many topics, right?
Yeah.
So for diuretics, you have your thiazide and thiazide-like. So you have, just remember which one is which, because it's always confusing when you get a case and you don't know which one is which. So hydrochlorothiazide, you're going to see always being referenced as HCTZ. This is a very, very common thing to see. And your thiazide-like is probably your most common one is indapamide and metolazone. They're not very used that commonly. For the most part, you're going to see hydrochlorothiazide used for blood pressure. Just remember that they are diuretics. So as the GFR goes down, as the kidney function goes down, if you got somebody with the chronic kidney disease, stage 3, stage 4, probably, they're effective. They're not very effective because the kidney cannot, diuretics don't work if the kidney doesn't work very well, because technically they have to let, fluids out. And if your kidneys are not working very well, the effect will not be there. Okay. You can use them in concomitant with the loop diuretics that potentiates the effect. That's mainly going to be happening if you need to remove a large amount of volume. So let's say you get a heart failure patient, they came into the hospital, their dry weight used to be 100 kilograms, now their weight is 125, 130. So you have 30 liters of fluids accumulated in that patient. You need to remove this much fluid. Probably you need to combine a loop diuretic with a thiazide diuretic to beat that effect. So you potentiate the effect. These will cause hypokalemia because they're wasting water. You're going to waste potassium too. Okay. So it's kind of the opposite thing. Always keep an eye on potassium. That's probably a good thing to remember. Loops probably are the most potent of the two. So if you think about loops, then probably thiazide and then thiazide-like. So loops, you got your bumetanide, furosemide, and torsemide. Very good tip to remember. They're not a one-to-one IV to oral conversion. Okay, you just cannot go and switch somebody from oral to IV or IV to oral. So let's say that patient who came with heart failure, we effectively removed this fluid and now they need to go home, but we need to switch their IVs to POs, right, to orals. It's not a one-to-one all the time. So think about it. I just included this table here. So furosemide, this is, I'm sure you're going to be asked this in rounds. PO is less bioavailable than IV. What's the bioavailability of IV, any IV medication?
100%.
Exactly, always 100%. PO is when you have to ask the question and then some other route of administrations. So torsemide is the same thing. You can do it IV or PO. But furosemide, unfortunately, this is always a common question. Now, my other question for you is that which one is the more potent of these? So let's say you got a patient with 50 liters, 60 liters of fluids you need to remove. What is the strongest loop diuretic of these three? Which one
Is it
is
Furosemide?
furosemide?
and why is that?
Because has high milligram, maybe. I don't know.
That's the opposite, right?
Yeah.
So bumetanide will give you 1 milligram of bumetanide will give you the same effect of 40 milligrams of furosemide. So bumetanide, you need just a little smidge of it to get the same effect of 40. So bumetanide is actually the most potent of them. Okay. So remember this, when you get a patient and you really need a lot of fluids removed, you probably best option will be bumetanide. You will see Lasix or furosemide. I included the brand name because it's so common and people will refer to it as Lasix. So Lasix is very common, but bumetanide is actually the most potent. So you can use it and you will find it usually in heart centers and, just in general hospitals. Okay. Again, hypokalemia is a very big deal. Now, one tip I want to leave you with also, you can also, because when you go to rounds, or you go to the bedside, you will be smarter than other people. Furosemide, like for example, it comes in so many doses. So if I give somebody a 20 milligram and then I give them 40 and then I give them 80, doubling the dose does not mean doubling the effect. Actually, as you go higher on the dose, the effect diminishes, it goes down. Okay, so not all of these medications, actually, if you double the dose, you double the effect. So if I remove 20 liters with 40 milligram, it doesn't mean I'm going to remove 40 liters with double the dose. Okay, that's why you will find some studies suggesting that furosemide after 100 milligrams is not actually very effective. So that's why probably if you go to the hospital and you tell them I want to do furosemide 200 milligrams, nobody is going to believe you because it does come in 200 milligrams, but nobody ever use it because it's the same effect probably as 100 milligrams. Okay, just keep that in mind as a concept for drugs because this is always interesting. Okay, potassium sparing diuretics, you have your amiloride, trimethoprim, probably you're going to see they're not very effective. The only reason they exist is because they spare potassium, so they don't affect potassium. They spare it, meaning they leave it alone, they don't touch it. And then you have your aldosterone receptor antagonist, spironolactone. So spironolactone was a very tricky one. Nobody exactly knows how it works because it's a multi-classical drug. So it fits in multi-classes. So in some references, you will see it as an aldosterone receptor antagonist. And in some references, you will see it as a potassium sparing diuretic. If you get asked on the board which one it is, it's both actually. Okay. They both are weak diuretics, but they don't cause any hypokalemia. This is for your own reference. Okay. Just to know where everything works. And then just to fit them all together in one slide, Dr. Iman prepared this slide, which I think is very nice for you guys to remember. Okay. And then you get your side effect profile. One thing to think about is they come in combos also. So you will find actually hydrochlorothiazide being combined with an ACE inhibitor or an ARB in one tablet. So think about kind of making the patient life a lot easier once you establish the therapy and you know you want to continue this for life or for like multiple years, there are combo tablets that are going to make it easier for your patient. Okay. Now let's go into a different side of the spectrum, and let's talk about sympatholytics. So things that actually act outside of the kidney. So beta-1 blockers, you got your atenolol, bisoprolol, metoprolol, and nebivolol, all of these. They're not actually first-line agents in hypertension. The reason is they
are affected like the insulin and other things. The beta blocker in the eyes and pancreas.
And the reason also they do affect a lot of things, as you mentioned, but they do also, how I say this the right way, I think we do have more effective medications. Okay. Can you guys hold just 1 second? Let me pick something really quick here. Sorry, we're back. You guys can hear me?
Yes.
Yes, sorry. Okay. So we said that because they're selective beta-1, they will not be your first choice for hypertension, okay? So just be mindful of that. They're not gonna affect your blood pressure to an effective way, but also they're not first-line agent in hypertension because they do not offer cardioprotection as an additive layer of protection for those patients, because we already said that end organ damage and cardiovascular risk is the biggest deal that we have in hypertension, right? We don't just care about the number. You guys know the saying that says treat the patient, don't treat the number. But we're not treating a number. We're not reducing the blood pressure. We're treating all these mortality and morbidities that come with the risk that comes with hypertension. This medication will not do that. Unfortunately, it's not one of the medications that have shown to reduce the morbidity and mortality. Okay, so the strongest evidence you will find for these medications is in heart failure, and specific these three medications. So bisoprolol, metoprolol, succinate. So metoprolol comes in two forms: long-acting and short-acting. I included here as just metoprolol because it comes in tartrate. That's the short-acting, that's a twice a day. And succinate is the long-acting, the once a day. Your evidence in heart failure is for the succinate formulation, the long-acting one, and nebivolol as well. Okay, and the side effects include depression because lower blood pressure, lower heart rate, bronchospasm, bradycardia, and erectile dysfunction. Okay, nebivolol has the lowest risk of ED compared to other beta blocker agents. Remember this one. This is very key when you go and see patients who are young but recently got an MI or an aortic stenosis or something like that, and then they put them out of once they out of the hospital, they have to be discharged with a beta blocker. Okay, now these are 45, 50-year-old men. If you give them ED for the rest of their life, they're going to be depressed, right? Erectile dysfunction is a big deal for these patients. So remember, nebivolol is your go-to agent in this case. Okay, just some tips for you. There are non-selective beta blockers, propranolol and nadolol, also not first-line agents. Still, beta blockers are not first-line agents. And one of the things is beta-2 blockade is a big deal. So my question for you to think about, and that's kind of the the highlight of this slide is what happens if a patient with asthma gets a beta blocker. So if you give them nadolol or propranolol, non-selective, and they have asthma attack, what would happen to them?
Bronchospasms.
Okay, so when somebody gets an asthma attack, what's the first thing they do? They use a rescue inhaler, right? Is it gonna work? Because the rescue inhaler is a
No.
beta agonist, right? It's not gonna work. It's a beta 2 agonist. It's not gonna work because you're blocking that beta receptor because it's a non-selective beta blocker, okay? So think about it this way also, because it might not be a good option for these patients. Alpha-1 and beta blockers. So you got labetalol and carvedilol, they have alpha blockade activity, and they're preferred with patients with PAD. That's kind of the hallmark. They come as an important rule later in pregnancy and hypertension. So labetalol can be used to treat hypertension in pregnancy. But those drugs you should not be using in just typical hypertension, okay? Just essential hypertension. Okay, this is just giving you just the kind of the diagram of how these fit together, okay? So just remember which one is selective, which one is not. Alpha blockers, or alpha-1 specific, alpha-1 blockers will be alfuzosin, doxazosin, prazosin, tamsulosin. Sildosin, I haven't seen before. I don't think it's very common. But one thing to remember about these medications, is that they come apparent in BPH only. So benign prostate hyperplasia. You're not going to see them used for hypertension. Hopefully, you're not going to be using them for hypertension because they shouldn't be used there. What they do is they bind to alpha-1 specific receptor in the prostate, and they dilate the prostate, okay? There's one specific tip here. Tamsulosin is the only one that is alpha-1A subtype specific, okay? So that one is going to bind also to the prostate tissue alpha receptors and only bind to the prostate. It's not gonna affect blood pressure. So let's say you've got somebody with BPH and they need an alpha-1 blocker, but their blood pressure is already low or borderline low. You don't want to affect the blood pressure. Your first option will be tamsulosin. The other ones, they're not specific to alpha-1A. They affect any alpha-1 in the body. So they will actually kind of reduce the blood pressure a little bit. That's why we are talking about them here, because they do actually affect blood pressure. Okay. Okay, we can affect blood pressure centrally, right? We can go to an alpha-2 central agonists in the brain, and we effectively reduce the tone of the peripheral and central vessels, right? Methyl-dopa can do that. The most common one is clonidine and guaifenesin and reserpine, not very common. I think the most common one you're going to be asked about are these two, clonidine and methyl-dopa. Again, not first line in hypertension. You will see clonidine being talked about a lot in resistant hypertension. If somebody has high blood pressure, but they can't get it down, they're going to start using these kind of agents. The side effects include depression, fatigue, nasal congestion, all of these things that comes with you if you just reduce the tone of the vasculature in the body. Methyl-dopa also can be used in pregnancy. So methyl-dopa, you will see it's used, probably the only use for it is in pregnancy, honestly. It's not used a lot in other things. Reserpine has sedative effect, and it indicated in psychosis. I haven't seen, honestly, that agent being used that way. Calcium channel blockers, you will have two things to remember about this. Dihydropyridine and non-dihydropyridine, know which one is which. Non-dihydropyridine, that's your diltiazem and verapamil. Hopefully, you're not going to be using that for hypertension. If you see diltiazem or verapamil being used, that's mainly a cardiovascular issue, either an MI or a stroke or something, okay? They do affect heart rate a lot. You will be seeing them used in AFib, so they're heart specific. Angina, they do affect the electricity conduction in the myocardium, so they do not actually work very well as they're an overkill for just the hypertension. Okay, dihydropyridines, no, they affect the basically they block the calcium channel blockers in the periphery, so they cause peripheral edema, and they are actually indicated as first line if you cannot use an ACE or NR. So let's say you got somebody with dry cough that doesn't go away with an ACE and ARB, you can use a first line agent as amlodipine for those patients. Okay, so remember these tips about but peripheral edema, you will see it, especially with high doses. Just remember your types of calcium channels. This is just to refresh your mind about what kind of types we are expecting. And then this is going to be your slide to tell you diltiazem and verapamil are kind of always in one group. So they had dihydropyridines, and these collectively we call them non-dihydropyridines. Okay, vasodilators. So they directly, so they provide direct vasodilation. That's your hydralazine. Usually this is an ICU medication. You're not going to see it used for just essential hypertension. Minoxidil, it's an old drug. It's not used anymore as it comes as an oral, or used to come as an oral medication. It still is available, but you're not going to see it as a hypertension treatment. Can you guess what this is used for? I think some of you guys probably have seen it in the market.
Antipsychotic or anti?
Minoxidil, it comes as a spray in the market. You will find it, people using it for.
Anxiolytic, maybe?
I can't hear you, sorry.
Removing anxiety or something?
Not really. As a hair loss medication. So because its effect is increasing hair growth. So increases hair growth. So it comes as a spray. You can find it in the pharmacy aisles, and you can use it. People use it who have people with alopecia or hair loss. They use it actually to generate hair, basically. So that's the only use for it. You're not going to see it as a blood pressure. So when they actually was using it for hypertension as a blood pressure medication, one of the side effects they notice is it actually increases hair growth. So that's why they use it. Sodium nitroprusside, it's only for emergencies. It comes as only IV. Nitroprusside, you're not going to see it as a typical medication for hypertension. This is your table to guide you. This is a table I also included to give you all the medications in one class. So any class you will have all the medications, and also you will get some of the remarks you have to know, and the common or the minimum and the maximum dose. Not that you need to remember the dosing, just for you as a reference. Okay. This is also, I think, a very helpful table to guide you through everything. So these are the most common medications, and you're gonna find. I just want to draw your attention to this column right here, or this row right here. It gives you an idea of why we're using some medications and why we're not using some medications, because we are using medications for hypertension or diabetes or some of those long chronic disease states, not just to impact the numbers, but also to offer other benefits, cardiovascular benefits, renal benefits, elongation of patient's life kind of benefit. And these benefits are actually, so we're trying to hit 3, 4, 5 birds with one stone. Okay, that's why we prefer some medications over the others. So when you talk about guidelines or how we actually treat the patient, there is so many guidelines I included in the first slide of this lecture. There's the TNC8 guidelines. You have guidelines from the American Heart Association. You have some international ones. You have some European ones. One of the most classical one that we're going to see in the hospitals being used either here in Saudi Arabia or somewhere else is actually GNC8. So one of the things to think about is to go through the diagram. So for example, it will ask you, is the patient 18 or older? Yes. Have you implemented any lifestyle changes? DASH diet, all of these things we talked about, exercise? Yes. So, and then you're talking about now lowering the medication, the blood pressure with the medication. So they ask you, is this patient has diabetes or chronic kidney disease? Yes or no? Or they have nothing. So if they have no chronic kidney disease, you look at the age, above 160, above 60, lower than 60, and you set the blood pressure goal based on this. So why if somebody is 65, the blood pressure goal is a little bit higher? We are okay with 150 compared to somebody less than 60. We are not okay with 150. We want them to be lower at 140. What physiological changes happen in the vessel as you get older? Your vessels become
Stenosis.
kind of, but the vessel wall, we're talking about the vessel wall here, they become stiffer, right? Old people have, yeah, that's peripheral resistance. That's because you have stiffer walls, right? So we're okay with somebody above 60 if their goal goes up to 150. So their goal here is lower than 150 over 90. And here it's lower than 140 over 90. It's going to be lower 140 over 90 across the board, except if somebody is more than 50 with no disease states, no diabetes or CKD. And then you go about whether they're black or non-black, because blacks don't have, the renin-angiotensin system is not that active. So you would start with a thiazide or CCB versus non-black, you start with an ACE and R. Okay, and then you go and reevaluate as a follow-up. So just follow this slide. It's a very easy thing to follow to determine which agent is the first. Okay, now practice pearls for hypertension. We already talked about essential versus secondary hypertension. So primary, when to check blood pressure during patient's clinic visit. When do you check the blood pressure? If the patient comes to your clinic, when do you check the blood pressure?
After he took rest, maybe.
Exactly, after they sit down and take a rest. So probably don't check it the first minute the patient comes in, because it's going to give you a false elevation. Check it when the patient is sitting down for 3, 4, 5 minutes. It will give you an accurate determination whether you need to treat or not. Okay. Goals of therapy, we already have it from the guidelines, right? So we're trying to reduce mortality and morbidity, and also keep the numbers less than 40 over 90, except for people above 60 with no CKD or diabetes. Okay. Which hypertension guidelines to follow? It's hard to tell, right? Because you will find that the American Heart Association guidelines, they have different goals here. They're actually more on the 130 over 90 goals, not 140 over 90. So the guidelines here, it depends on a lot of things, depending on your hospital, what protocols they use, depending on what other disease state the patient has. So for example, the KDIGO guidelines, the kidney disease guidelines, they will be more in corporate of patients with kidney disease. So they have different goals. So depending on the patient population you're caring for, they will determine what guidelines to follow. How to manage orthostatic hypertension. Somebody takes this medication, ACE inhibitor on ARB or something, and then when they stand up, they get dizzy. So that's orthostatic hypertension. So it actually gets better with time. So just tell them to stand up slowly, hydrate properly, and they will be fine after a few weeks. What's the difference between target dose and initial dose? So when you talk about, for example, these medications, we talked about some of the thiazides, and we said that above 100 or 200 or 160, 180, it's not going to be as effective as if you just stop at 100. So that's the difference between a target dose and initial dose. Sometimes there is a dose you're trying to hit. Sometimes there is an initial dose you just start with to see how the patient reacts. So don't use just the word dose, because dose means a lot of things. Is it initial? Is it target dose? Is it goal dose? Is it titration dose? Is it treatment dose? Is it maintenance dose? There's a lot of dosage, okay? So just try to formulate your vocabulary to be more accurate. When indicated, always start with an ACE, then switch to an ARB. We talked about the story with the cough. Be careful when prescribing beta blockers to young males. We talked about the ED, and nobody's going to tell you that they have ED until they have that trust, patient provider trust, okay? But it does happen almost all the time when you prescribe beta blockers to young males. So don't do that unless you have really absolutely exhausted all the other options. And then patients with diabetes, why would you not give a beta blocker to somebody with diabetes?
Because of pancreas, beta cell pancreas.
Yeah, because of the insulin.
Not really. I mean, there's beta here and beta there, but that's not what I'm looking for.
ACE inhibitor has a protective mechanism for diabetes patients, I think.
That's very good. Actually, that's true. But
May
beta
not
blocker,
develop hypoglycemia.
what's the risk if you give somebody a beta blocker when they have diabetes?
risk of hypoglycemia.
Exactly. So what happens if they get a hypoglycemic episode? Are they going to feel anything?
No, it's masked symptoms.
Exactly. What's the only symptom that doesn't mask?
Sweating, muscarinic
Sweating.
receptor.
Exactly. So if somebody is not much of a sweater, they're not going to feel anything, because once you get hypoglycemic, your heart rate goes up. That's a sympathetic effect, but you're blocking that. You're not going to feel it. The heart will not kick in. The heart rate will not go up. The shakiness you're not going to feel. A lot of the effects that you're going to feel as a hypoglycemic diabetic patient, you're not going to be feeling, and except sweating. Okay. And then always assess pregnancy risk or potential. This is a very, very important thing. Okay. Very quickly, dyslipidemia, they tie together. I know the time will not be, they're two different, but just bear in mind that lipid metabolism, how it happens, just follow the diagram, how the small intestine actually get that kind of microns, and then how they go to the capillaries, and how the liver actually synthesizes cholesterol and uptakes cholesterol, and how the adipose tissue happens. Because these things actually, the basic science, but we're going to apply a few things to it. So first thing we're going to apply is the lipid profile. So a lipid profile, when you order it, it comes as a set. You have your total cholesterol, you have your triglycerides, HDL and LDL. Which one is an actual measure and which one is a calculation? You guys know how these numbers come? So does the lab actually go in and get the sample and measure every one of them?
By calculation.
It's an equation, right? So total cholesterol equals LDL plus HDL plus fifth of triglycerides. So if your HDL or LDL, let's say LDL, if your LDL is super elevated, but your triglycerides are fine, your total cholesterol will be high because the equation will change, okay? So just remember which one is calculated, which one is, so TC or total cholesterol is actually calculated. Nobody goes and measures your TC. Okay, these are the typical numbers you're gonna get. If you want them to be less than this, which one is the best, is the good cholesterol, as they say?
The dense cholesterol, HDL.
HDL, exactly.
HDL, yeah.
Still. Okay, these are the drugs we're gonna be talking about mainly. I included a new class of agents that just came recently, so we'll talk about it. This is telling you about all of the agents and their names and giving you some considerations just for your own benefit. Pay attention here to what's happening with LDL, HDL, and TG, because some of them affect LDL more than HDL. Some of them affect triglycerides more. And we're gonna start, we can try to highlight that. We're not gonna go over how they work. You guys can reflect back on this slide as we go through the individual agents. So first of all, statins, your classic medications, simvastatin, lovastatin, atorva, prava, and all of them. They're HMG-CoA reductase inhibitors. That's the limiting step in cholesterol synthesis. They decrease hepatic cholesterol biosynthesis by limiting the rate limiting step, as we said with HMG-CoA reductase. They are different in potency. So think about this table here. So intensity of the drug is different. So for example, your pravastatin is a low intensity. Your atorvastatin is high intensity under the right dose. Okay, so let's go through it. Pravastatin, if you give somebody 10 or 20 milligram pravastatin, you're going to reduce their LDL by about 30%, no more than that, their LDL, okay? Your moderate intensity statins, they can do LDL reduction from 30 to 50%, depending on how much you're trying to accomplish with this specific patient. Because hyperlipidemia has a tied risk also with cardiovascular disease, right? Because it's an atherosclerotic cardiovascular disease, right? Your high intensities, I think the easiest way for you guys to remember it is that remember the high intensity and remember the low intensity. Anything that doesn't fall in these groups is a mid intensity, okay? So the high intensity is dose dependent. So look at that. Rosuvastatin 20 is actually a high intensity, but rosuvastatin less than that is not. It's a moderate intensity. Atorva 40 to 80 is a high intensity. So atorva 40 or rosuva 20 is a high intensity. One of the things you're going to notice also is that they affect everything, LDL, HDL, and triglyceride. They do affect cell growth and differentiation. The hallmark side effect will be myopathy and rhabdomyolysis. Why is rhabdomyolysis a big deal? Why do you care about it here? What happens if you break chunks of your myocytes? What if you have myocytes, just chunks of muscle just circulating around? It clogs your kidneys, right? So it can cause acute kidney injury. So it's not a good thing. Also, it's not a pleasant feeling for the patient because it's an overall muscle pain that they're gonna feel, okay? Remember, it's contraindicated in pregnancy and lactation. They do, all of them go through the liver. So if you have a patient with active liver disease, these drugs will not be metabolized. So be careful with that, except one drug, pravastatin. And I think it's probably a board exam also. So if you have somebody with an active liver disease, if you have to absolutely use one of these agents, it would be pravastatin, because that one does not go through the CYP enzymes. It does not go through the liver. Okay. That's how they work. If you guys are following this slide or the previous slide, it's fine. Your second agents will be fibrates. That's your gemfibrozil and fenofibrate. And whenever you hear fibrates, it's always bad news because they do interact with a lot of agents. They have a lot of drug-drug interactions, okay? So always fibrates is always a big issue, okay? So they agonize the PAPAR receptor. So they increase, so the expression of gene responsible for increased activity of plasma protein lipase enzyme. Basically, they affect triglycerides. So you're not going to be using those for LDL or HDL. These are only for triglycerides. So let me ask you a question. What is a high triglyceride? What's the number?
100 and
depends on the unit, right? But let's say milligram per deciliter. You want a healthy adult to have less than 150 milligram per deciliter triglycerides, right? That's a normal lipid profile. But what if we say this guy has a triglyceride of 500? What is the issue actually? Why do we care? Like when it reaches 500, what could happen? It's a good question to ask, right? Because why would you use this medication then?
maybe like he doesn't have the receptors to metabolize those proteins.
If I'm running around with a triglyceride of 500, what could happen to me?
Enhancing atherosclerosis, for example.
That's true, but that happens over time, right? It's not a quick thing. We'll talk about this in a little bit.
Yeah.
That's a 10-year risk. It's not a one-day risk.
Fat embolism?
It's actually a weird thing. It's pancreatitis, actually. Okay.
Mm.
So as triglycerides go above 500, the guideline will cap you at 500. We'll tell you, please reduce it below 500. But it's the risk of pancreatitis that we're worried about. Okay. Technically, pancreatitis, if you ask internists, they will tell you it doesn't happen. They don't worry about it until it reaches 800, 1,000 milligram per deciliter. Okay. So pancreatitis. So effectively, if you want to reduce triglycerides for somebody, these are the drugs to go for. Okay. Fibrates that are contraindicated in pregnancy and lactation and active liver disease. Same way. Caution with patients pre-existing gallbladder disease, because again, same thing, because where the fat gets metabolized, what do you need? What do you need also to metabolize fat? You need secretion from that fat, right?
Both bile and
Yeah, you need the bile. So think about it this way. So you will have to be careful with these medications. Drug-drug interaction also is a big important thing. Less important medication that you're probably not going to see a lot is nicotinic acid. So niacin is the most common one. You can read the mechanism of action. You're probably not going to see the drug, honestly. One thing you're going to see when patients take niacin is flushing of basically facial flushing. And they remember in pharmacy school, one of the professors used to bring niacin in the class, and he has us take one, and you will see the flushing right away in a matter of a few minutes. Okay, it does affect LDL and HDL in a positive way. So HDL goes up, LDL goes down. It's contraindicated also for liver disease and peptic ulcer disease because it's a little bit harsh on the stomach. It's not a first-line agent that you're probably going to see. It's not very common. One interesting class of medication is a bile acid sequestrants, cholestyramine, cholecalciferol. These are the two probably most common one. Cholestyramine is probably the common one. These are anion resins. They basically bind to bile acid and fat, so they prevent them from being basically absorbed. Okay. So what do you think the side effect would look like if you keep your fat in the GI system, in the GI tract?
fatty diarrhea.
Constipation, right? Some patients will get diarrhea, that's true. But then they'll get indigestion, local effect. If somebody has bowel obstruction, you're not going to use these because they do keep things in the bowel. So you don't want somebody who with a bowel obstruction and then probably bowel rupture or something like that. You try not to use them when you have too much triglyceride. Again, for the same issue that probably you have more effective medications. You have these. You have the fibrates. Not a first-line agent. If you actually if you have a resin that binds things in the bowel, they're going to bind everything that is fat or fat soluble, including your fat soluble vitamins. And that's A, D, E, and K. Okay, this is very important to know because especially if you have somebody who is deficient in any of these. Ezetimibe, that's absorption inhibitor of cholesterol. One thing to remember with this medication is you're probably not gonna see it a lot. It's not very common, but this is probably more of a diarrhea kind of a picture, but it does not affect fat soluble vitamins. But I doubt you're gonna see this medication a lot. It's not very common. Statins and probably fibrates are the most important ones. The last but not least is your PCSK9 inhibitors. These are newer medications. They just came to the market within the last 5 years. These medications are injectable only. So they're actually a biological agents. You can read the mechanism of action here, but basically what they are good about is familial hypercholesterolemia. So those patients with very, 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 very high cholesterol because of their genes, right? They're just born with this. It's a hereditary thing and they need to be taken care of. So these patients require 70, 80, 90% reduction of cholesterol. Statins can only do up to 50% reduction of LDL. Those patients need a lot more. So this is kind of an overkill for a normal patient. This is preserved for somebody who needs a huge LDL reduction. So they have a profound effect on LDL, and this is underlined. Please be careful with this one. And then they do affect other things as well. They're your typical biologic. They're gonna have flu-like symptom. The patient will do have flu-like symptom because you're injecting things the patient is not used to. Injection site reaction. Other than that, there's not a lot of side effects, honestly. They're very mild medications. They're dosed once or twice monthly, which makes them a very useful tool. These medications are not usually handed to the patient. They actually usually given in a clinic environment. So the patient goes, walk into the clinic, they get vitals and things, and then they take, ask the patient a few questions if they have any issues with the previous doses that they got, and then they get a dose once or twice monthly, and they go home. So these came in 2015. They were actually a big breakthrough in treatment of hyperlipidemia. I remember the American Heart Association was very thrilled about these agents. So they're kind of a breakthrough, as well as statins when they came out. Okay, so let's talk about the point that one of your friends just mentioned about the risk. So if I have a high triglyceride or high LDL, that is a high risk for atherosclerotic cardiovascular disease, but for how long? So am I going to die today? I mean, God knows, but is it going to kill me today, or is it going to kill me next year? Or how long is the issue going to last that I'll start caring about it as a clinician? So a lot of the things actually tend to happen over a long time. So these are chronic disease issues. The lingering effect will happen over a long time. So we have these studies that actually trying to estimate or link cardiovascular disease with hypertension, cardiovascular disease with LDL, for example. And we do have calculators to calculate the patient's ASCVD risk, so atherosclerotic cardiovascular risk, over 10 years. So if we give somebody a statin to reduce their risk, you're reducing the risk over 10 years. If you give somebody a baby aspirin, an 81 milligram or 100 milligram aspirin, you're reducing cardiovascular risk, but not today. The patient has to take it every day for 10 years to actually guarantee a benefit, because statistically, we don't have anything less than 10 years. We only estimate things over 10 years. That's the best data we have. So remember, if somebody who don't take aspirin and they don't want to take statin, it doesn't mean you don't give it to them. It just, they have to understand this is a 10-year risk we're trying to go against, okay? Risk can change over time. Of course, patients can pick up smoking. They can do other things that can increase or decrease their risk. And note the different variables that goes into the calculator. So I linked the calculator here for you guys so you guys can go and play with it. But look at the variables. It takes your age, the patient gender, race, systolic and diastolic blood pressure. They take their lipid profile into considerations. These are things that are going to play a factor, a variable in your ASCVD risk. History of diabetes, smoking, aspirin use, statin use, and hypertension. So these are all variables that can actually impact your risk for atherosclerotic cardiovascular disease. Okay, so you guys can go to the calculator, play with it, and see what the risk has to be, because this is what the guideline is based about. So if you look at primary prevention for atherosclerotic cardiovascular disease, this is from the American guidelines. You can see that once you have a normal patient, depending on their age, your second step is to see what their atherosclerotic cardiovascular risk looks like. So you have to do the calculation. It does exist as an app as well. You can download it from the app. If you put the AHA, American Heart Association, 10-year ACD risk calculator or something like that in your app store, you will get it. And then that, based on the risk, if it's above 10%, this is where you start implementing some of those medications and trying to reduce the LDL and trying to reduce also other variables as well, lifestyle and things like that. Okay. Versus if you look into if somebody has high age, like 75, if you look in somebody with diabetes, or if you look at somebody also, sometimes they look into somebody with secondary prevention when you talk about somebody with an MI or a stroke. But for primary prevention, you need to do, how much risk they have in the next 10 years to actually start discussing these things with the patient. Okay. If they do have a clinical ASCVD, so they already had an event, this is secondary prevention. They already had an MI, they had a stroke, they had something. That's a different story, okay? Because now you already had the risk already, the SCVD risk have happened. You're trying to prevent the second one. In that sense, you still have lifestyle modifications to do, but what's the risk for ASCVD? And you go from there. How do you determine which one is which? Based on this table. I just got highlights from the guideline to tell you how they actually go through determining the risk. So major ASCVD events are these, and tells you here, the very high risk includes these disease states. And then you also have to do some calculations. Some guidelines recommend also calcium screening or calcium screen, they call it. They have to look into the calcium buildup on the coronary arteries and things like that. There's like some high risk conditions also. You can think about the smoking, diabetes, hypertension, your typical risk indicators also. Okay, so for these things, I just wanted to go through it. If you have any questions, come and ask, but basically it's self-explanatory. Just focus on how you calculate the risk. Make sure you go into the calculator, know how to calculate the risk. And then here, know the difference between secondary prevention and primary prevention, because it follows different pathways. Okay. Any questions you guys have? I know we're exactly on time.
Let's see, Doctor, I have one question.
Sure.
Doctor, I know that hypertension, for example, is a cause of death. Okay, so if I have a drug that's proven to lower the blood pressure, how it sometimes it doesn't decrease the mortality if it's decreasing the cause of the mortality?
Yeah. So remember, hypertension by itself is not the issue. It's a multifactorial issue. Okay. So you're thinking about hypertension, and then you're thinking about some things that you can actually change. So for example, if you detect hypertension, so you detect this patient that is hypertensive, they get the label of hypertension today. Were they hypertensive starting from today, or they have been hypertensive for a while? You just didn't know. Right? So they have been running with it. Yeah. So some things have already happened. So we need to look into drugs that have positive outcomes in the studies that we know about. So ACEs and ARBs, they do have positive outcomes that we care about for those patients. Other medications, they just don't have positive outcomes. Another thing to think about these outcomes, the same thing exists in so many other disease states. So for example, for diabetes, if you go to the FDA today and you find a tree that has a specific agent or a specific chemical that reduces glucose, blood glucose, is that a good reason for the FDA to approve it? Actually, no. So there is a lot of things that actually reduce blood pressure. They just do not do the ultimate benefit that we're looking for. So same thing with diabetes. A lot of the things that has to do with diabetes has to do with the macrovascular and microvascular complications. So started from strokes and MIs to microvascular complications like retinopathy, nephropathy, and all of these. You will have to show the FDA positive evidence for cardiovascular and renal protection in 2021 to get a drug approved. Lowering the glucose only does not do that. How many drugs do we have for diabetes? So many. Do all of them do cardiovascular protection? No, although they lower the blood glucose, they don't actually cause any other benefit. So some of them actually cardio harm. They do offer cardio harm. So it's not always a clear picture. You will have to go through the whole gamut of actually determining, is this agent ultimately the good agent for the patient long term? And that's the question you need to be asking. But do they all lower blood pressure? Yeah. If you just need to lower the blood pressure short term, There's this agent, and there's probably another list of agents you can use also to lower the blood pressure. But they don't always. Minoxidil does that. It will lower your blood pressure, but it doesn't offer any other benefit. That's why we toss it out of the guidelines. Even there is no mention of it anymore.
Nice. Thanks.
Okay, so that does that make sense?
Yeah, now it does. Thanks a lot.
Any other question? That was a good question. And there are a lot of trials, and that's what the guidelines are based on. They usually assess risk and benefit long term, and they give you your options based on all of the evidence we know about the specific drug. So it's not as simple as, oh, I need something to lower this number. I need a vasodilator. I need vasodilator. I need something to impact the heart rate, impact we all know these things actually do impact blood pressure. In fact, if you ask me, my choice of blood pressure medication to impact the blood pressure the most will be clonidine, right? That's centrally acting. It will definitely lower the blood pressure for any patient. If you give it to a horse, it will lower the blood pressure, right? But the problem is it doesn't do the ultimate benefit we're trying to think about when we think about hypertension. It's okay to use an emergency situation for somebody who's in ER and their blood pressure is so dangerously high. That's fine in this scenario because you're not worried about the long-term effect because you're not going to use it long-term. But somebody with hypertension, essential hypertension, they're going to be using it for life probably. And you need to think about what happens in 10 years. Inshallah, when we visit the heart failure lectures, we're going to be more invested into this long-term effect thing. And you're going to see the difference between drugs and why we use this drug versus this drug when the FDA discovers another drug that is actually more beneficial in the long run, they just replace it right away. And the guidelines just shifts really quickly. And you see that rapid shift in the guidelines as the evidence comes along. So it's very interesting. It's always very interesting. And that's why when you are not, so think about it, how it impacts you as a physician. Let's say you're taking care of hypertensive patients and you graduated 20 years ago and you're not keeping yourself updated. You're probably still using minoxidil, right? And that's not what we're trying to do for our patients. We need to be updated all the time because things do come along, especially in pharma. They do update a lot.
Yep. Yeah.
Cool. Any other question for you guys? You too. Thank you so much, all. Thank you for your time. Sorry for giving you a hard time looking into the long-term effect, but inshallah, as we go along, things will be very clear. I remember my office where if you need any questions, just come along, email me, do anything. I'm always available for you. And until next time, inshallah.
Inshallah.
Assalamu alaikum.